Now, over here, you'll see other people pop up every now and so if somebody has a question,
That's pretty much right.
17. Oh, what's that?
I'm monitoring the Facebook and Twitter.
No, they give me a survey to have that.
I left my cards in the phone. Do you have a second USB? Does that have a second USB? Yeah. Let me go to the start without using my USB cord.
Awesome, bitch. So, what I do? You can, once the comments and stuff, we'll see what's okay. Okay. So, if we get it, right now, every question, wait till we get like 3 or 4. Just what should be. Okay. Where are you? Okay. Ship right there. Window with it. Yeah. Okay. Alright.
Well, if you can work from home, then you $500 a week. And I'm like, oh, really?
Okay.
I'm like, yeah, there's something to be $2,000. But
I've been in my truck since 4 o'clock. I drove up here from here. Get a crown.
We've got
by the way, I'm a data publisher.
Oh, okay.
I need to probably letter with her.
Thank you.
That's a good thing.
And then where you make me from going.
Is this going to try and say I'll have to click the thing on truck, right? There we go, charging on.
It's the thing about those two right now.
Yes.
Okay. Yeah, fantastic.
Hello, ladies and gentlemen. Thank you. Can you hear me? Yes? Do I even need this? No, I didn't think so. Won't be the first time. It's okay. On behalf of Team Friendly and Emory School of Medicine, thank you so much for joining us for this town hall forum on PrEP therapy. One of the first things we want to thank you for coming here and bringing the traffic. Also, we want to talk very briefly about the friendly approach. Although we are okay. Although we know that this is a hot button topic, at Team Friendly Atlanta, we choose to try to meet people where they are and make sure that people understand that regardless of our passions and our personal perspectives, that we are respectful towards everyone's opinion. The goal of tonight is not to talk about the personal stories or the personal, it's a party drug, are you this, are you that. We're here to talk about the facts and to talk about personal experiences on PrEP. So please keep that in mind, and if per chance someone gets a little more passionate, I might cut you off. Please take no offense to that, but we're trying to keep this on track and make sure that we're able to provide a lot of information tonight. With that, I would ask everybody at this time to please silence your electronic devices so that we can be totally focused on our incredible panel. And it's time, I'm going to say that aloud. I would like to introduce our panelists. Each of them is going to have about 5 minutes to kind of explain their background, why they're here, and their personal perspectives on PrEP. And I will start with Dr. Colleen Kelly of the Emory School of Medicine.
Hi, I'm Colleen Kelly from Emory, and I'm an infectious disease doctor who primarily specializes in HIV treatment. On the clinical side, but on my research side, I've been interested and been working for a very long time in HIV prevention in various fields. And so,
You're not as loud as I am.
oh, sorry,
There you go.
I don't need to start. Okay. And I guess I don't need 5 minutes, but I think that this is a very exciting time, the last probably 2 to 3 years in HIV prevention, where we have a lot of new interventions coming through the pipeline that are going to help reduce people's risk of acquiring HIV. And I think we need to get the word out as much as we can and get people aware of these interventions so that we can reduce HIV incidence, because that's the primary goal is prevention.
Thank you, Kelly. And then this is Olga, the scientist from Gilead.
So I'm actually pretty loud. I would say I'm Puerto Rican, so Puerto Ricans are loud. But so my name is Olga Lugo. I'm a physician by training. I saw patients for 21 years in the cities of New York and Chicago. The last job was in the Department of Health. And I have been with Gilead now for almost 4 years. I'm one of their medical scientists on the community side and cover the southeast of the U.S. And again, I was in the beginning. I want to say thank you to Randy that extended the invitation to be part of this panel, and I concur. That's a nice word, concur. With the Dr. Kelly here, is that it is important. One of the main issues that we find is that the community is not aware of this. And I think that one of the things that we want to remove is all this stigma that is being created around this tool also. And the only way that we can do that is through education and talking openly about what are the possibilities and who should be engaged with this tool. Again, I'm trying to be as fair as possible, and I'm trying to give you an answer to any of the questions that you have. But obviously, we don't have the answers to everything. This is something that is pretty new, but it has proven to be effective. And again, this is something that we encourage you not only to get your answers, but share this information with so many people that are in the community that don't have the opportunity to come to these meetings and And one of the ways that we think that we can get actually the providers involved and more motivated to do that is when actually a patient goes into the doctor to see their PCP and actually ask for these services. So we encourage you to get as informed as you can and make this decision with your provider and decide if this is a strategy for you. Thank you.
Thank you. And then Jeff Graham from Georgia Equality.
For those of you who don't know me, I actually have been involved with HIV advocacy and activism since the mid-'80s. My own journey kind of started off as a student in college, then was extremely involved with ACT UP activism for an extended period of time. Ran a statewide advocacy organization for several years called AIDS Survival Project. That a lot of our focus was on treatment issues and treatment education. I'm now these days, for the last 6 years, I've been here at Georgia Equality, and I work much more specifically in the realm of politics, policy, legislation. I think that there's a huge number of implications for PrEP in the work that I do around policy, especially some of the issues around funding that are unique to Georgia, but are kind of challenges nationwide. And in my own views on PrEP, I will gladly admit this. I have been one of the dinosaurs that has needed to be moved on this issue. I was really slow to embrace it. And we can talk more about this in detail, but condoms and needles are underutilized and are so cheap. And I do have some, especially when these conversations were first starting over the last 5-6 years, that was the time that our biggest struggle was actually making sure that people who were living with HIV had access to antiretroviral therapies. Again, I've come a long way with that, and like the previous panelists have said, I'm now very solidly we need to utilize all the tools in the toolbox. This is something that we begin to put pressure on some of our local planning bodies, some of our local officials to begin to get educated and embrace and plan for PrEP. And so my hat's off certainly to Team Friendly for doing this, because I think this is one of our first town hall community conversations on it. Very much overdue, but at the same time, it's also very timely. In many ways, conversations will be starting from this place forward with the CDC's announcement yesterday that they have worked solid guidelines.
Thank you, Jeff. Dylan is one of our panelists who has first-hand experience with PrEP therapy.
All right, my name is Dylan. I don't know why I argued that. You already said it. I'm Randy generally, so I fluctuate, but I'll try. I am the co-chair and one of the founding members of Team Friendly Atlanta. Also, I've been on PrEP now for around 1.5 years. On the personal side, I have been nonprofits for several years now. I've been Team Friendly since we founded the organization in December 2012. And I am also the director of communications for a nonprofit called Peace Building Solutions. The past several years, I've been in communications in various different forms, and so one of my largest focuses has been making sure that processes and new ideas, new technologies, new procedures can be effectively communicated to populations that might not exactly understand. And one of the largest issues we have seen with PrEP has been a lack of effective communication and a lack of knowledge of communication. Especially in the early stages, there were so many people saying, you know, it does this, it completely prevents everything, it only prevents HIV, it doesn't prevent HIV. So one of the things that I've been very focused on is making sure that there is some source, some access to knowledgeable and effective communication. And so I'm so glad that Team Friendly is able to provide this town hall to the population and via webcast to the community at large. I feel that it's something that's most definitely necessary. I don't get too far into my PrEP because most of the questions answer those. So if I start giving those now, I am wasting the question time. So with that, I will pass it off to
And Lee has also got first-hand experience with PrEP therapy.
Hi, my name is Lee Scholl. I'm 36 years old. I have never known sex without fear of HIV. From my earliest sexual memories, the idea was, in my lifetime, I'll find her and I'm worried about this anymore. Here I am, I'm 36. I haven't gotten there yet. I am a high-risk group, and I don't look like it. I am genderqueer, I'm pansexual, I'm polyamorous, and I'm gay. And I have the experience of doctors looking at me and going, oh, you're a middle-aged woman. You must not have any HIV risks. I am a social justice activist. And so the safe-sex education and outreach directly impacts me, my community, people I love, and as an activist, I cannot be stopped at that. I have, I don't have any personal titles, I don't have any organizations, but I have participated in any way that I can with education and outreach since my late teens. I really thought through all that involvement, I understood what the stigma and ignorance was like, what it was like for someone who had HIV to deal with systems within society. And it was not until about 2 years ago when I began dating an HIV-positive partner and going through the medical system with him, going through the process of getting a PrEP myself, and being, as usual, my out and loud activist self about the whole process, I began to really understand what it was like. And I was shocked. I've had over a decade of dealing with these issues, and I really thought I understood, and I did not. PrEP is the closest thing to a cure that we have. It's not a cure, but it is a fabulous prevention. The efficacy rates are through the roof. And the fact that this is not being shouted from the rooftops all across America astounds me. So I will do anything that I can to educate more people and push this out there.
Thank you so much, Lee. There are a few organizations that I would like to go ahead and thank. First of all, Emory School of Medicine. They are two of the people who you're going to interact with tonight are from there, and without them, we would not have Dr. Kelly here this evening. So we're greatly appreciative of that, not only for what she brings to the field, but also as a doctor and her firsthand experience with patients and all of that. We'd also like to thank the Visitor Center of Positive Impact. It is with their help and their continued support that Team Friendly Planet has been allowed to make an incredible footprint within our community. They are also the person who was able to put us in touch with Olga so that we were able to have her here tonight as well. The Hope Clinic, as you came in, you'll notice there was 2 tables. On those tables, you will see that there is information for you to become involved on a research type basis. Right? Yes, trial studies. And so if you're interested in taking it a little step further after this evening, and it is something that you would like to be involved with, Mark would be more than happy to tell you what's available through Emory and the Hope Clinic. Finally, we would like to thank our media sponsor for this event, which is the Georgia Voice. Again, another organization that from the very beginning has been exceedingly supportive of Team Friendly and our mission to create an HIV-neutral community. We know at Team Friendly, based on all of our personal experiences, that the stigma related to HIV and the topics around it not only happen to those people who are HIV positive, but in the instance of PrEP, happen to those who are HIV negative. So we're trying to cut through some of that misinformation, trying to cut through some of those emotions that are very valid and very personal. But more importantly, we know that this is a bigger issue than any one person or any one organization. So that's one of our goals, is we are utilizing our resources to bridge the organizations in town. If you have something after the meeting that you would like to present to Team Friendly as an opportunity to come speak, or that you would like to partner up with us, we are more than happy to talk to anybody. Again, it's that bridging element that makes us as effective as we are. So with that, I'm going to turn this over to Dale of the Emory School of Medicine. She is a licensed RN, and I will give her 2 seconds to kind of give a brief introduction as well.
And I'm going to need that mic.
That's like,
I'm Dale Maddox, and I'm a clinical research nurse with Emory University School of Medicine, and I'm part of the AIDS Clinical Trials Unit. AIDS Clinical Trials Group is the largest international HIV research network in the world. We're the gold standard of clinical research. And as Randy mentioned, we provide a lot of variety of clinical trials on different scientific concepts. Mark has flyers and information, and he will be talking about that later. When I first approached Randy last year about doing this town hall, it was because I kept hearing a lot of misinformation and a lot of statistics and a lot of misunderstandings about what PrEP is. I am part of the gay and lesbian community, and I'm a research nurse. So my foot is in both worlds. So I decided, and I talked to Randy, I think it's a good time for the medical community and our community to have a discussion and have some open dialogue about this and clear up any misinformation so that people can make informed choices. Right? So, with that said, a couple things I am required to tell you. I do not have any financial interest in Gilead Science. I am not one of the clinical research nurses on any of the studies that I'm presenting. And as an aside, coincidentally, the CDC updated their PrEP guidelines yesterday. So we are getting a lot of press. New York Times did a major article. So did NPR, Bloomberg, and here we are. I swear to God, it really was a coincidence. So,
Real quick, Dale. So if all of our panelists, especially the females, those who are attending this via the webcast are having a little harder time hearing you, so please do take that microphone and make sure it's close. That way the information goes through the speakers and is being able to be picked up from the webcam. Thank you.
Okay, so let's go on and demystify PrEP. Next slide. Are you prepped? PrEP stands for pre-exposure prophylaxis. Next slide. Why do we need this? Public health impact. Every year, we have 50,000 more people infected with HIV in the United States. Every year. And that is despite the fact that we have all these available prevention methods, treatments, education, and this has been going on for 30 years. We need other approaches to make a dent, to reduce that 50,000, which has remained stable for the last couple of decades. And the other thing that's important is, at least back in when the CDC was calculating, in 2011, men who have sex with men accounted for 79% of new HIV diagnoses. That's an important number. Next slide. This is a graph. This is again in the United States. You can see that men who have sex with men, the trend is going up. We don't want that. It's going up now. Everyone else, IV drug users, heterosexuals, are going down. Next slide. All right. There's a variety of really cool biological prevention strategies right now. PrEP is one of them. If you're HIV positive, one of the strategies is if you are on antiretroviral therapy and you're undetectable, that drastically reduces your chances of transmitting it to other people. We actually call that TASP, treatment as prevention. If you are HIV negative, we have PrEP, which you take before you've been exposed to HIV. And there's also something called PEP, post-exposure prophylaxis, after you may have been exposed to HIV. Next slide. PrEP versus PEP. I know they're cute little acronyms, and everybody mixes them up. And there's been a lot of misinformation about that. I had a patient ask me about this yesterday, actually. Post-exposure prophylaxis and PrEP are similar. They both use anti-HIV drugs to prevent infection, right? But PrEP is before, PEP is after. PEP uses different medications for a different length of time. It is not the same. Next slide. Defining PrEP. All right. So we talked about that it's a novel HIV prevention strategy. Again, medication is taken before exposure to PrEP, and it's for people who are at high risk. And you take it's one pill once a day. And it should be used with other prevention strategies. That's the thing. It's not a panacea. We use condoms and other prevention approaches. Next slide. We should take it. All right. It's not for everybody. All right. If you have some unprotected sex with someone who is HIV positive, this might be for you. If you're in a relationship with someone who's HIV positive, if you have sex sometimes without a condom, fair back. Okay. Sex with a person of an HIV status that may be at risk for it. If you have a partner or you that was recently diagnosed with a sexually transmitted infection, because that could also put you at risk for HIV, right? And if you use illicit drugs for alcohol dependency. Why is that there? Because you are more likely to engage in this behavior. That's why. Frequent changes in sex partners. Next slide, please. How is it used? All right. PrEP is a combination of two medications, emtricitabine and tenofovir. They're sold together as Truvada. So it's two medicines in one pill. All right. We have been using Truvada to treat HIV since 2004, but it was approved by the FDA as PrEP in 2012, in July of 2012 to be exact. It needs to be taken every day, and if when used consistently, and that's the operative word, consistently, PrEP has been shown to reduce the risk of acquisition of HIV. It requires strict adherence to daily medication and routine HIV testing about every 3 months. Next slide. Next slide. So how does it work? It inhibits HIV from replicating in the body. By doing that, it prevents HIV from establishing permanent infection. That's a very simplified way of explaining it. Next slide. All right, again, it's not a panacea. It's not always effective at preventing HIV infection. It is not 100%, guys. Right? It must be used in a comprehensive prevention strategy, safer sex practices, routine HIV testing, and it has got to be prescribed only to people who are HIV negative. That is huge. It has to be prescribed to someone who's HIV negative. If that person unknowingly is HIV positive, they will quite likely develop resistance to that medication. They should not miss any doses, and again, missing doses may increase the risk of acquiring HIV. Next slide. Picture condoms, I thought was cute. Next. This is the important safety information from Gilead about the negative status. And again, we're not going to prescribe it to someone who has symptoms of acute HIV infection. So these are common symptoms: fever, headache, fatigue, pharyngitis, rash, etc. So if you're in the process of seroconverting HIV and you're on Truvada, you may develop resistance to it because 2 drugs is not enough to treat HIV. We can ask the panel if you have any questions about what that means. All right. HIV-infected patients taking Truvada, they must take it with other medications to fully suppress it. Okay, so Truvada alone is only good to prevent. Next slide. Okay, clinical trials. This is going to be brief, but there were 2 huge trials, right? That this is where I kept hearing a lot of this information. IPREX. This is was evaluated almost 2,500 HIV negative men or transgender women who had sex with men. This was an international study. I think I have written down what countries. It was several countries in Africa, Brazil, the U.S., and I think it was right here, and South America. Also, we had partners PrEP, and that was conducted with 4,758 heterosexual couples, where one partner was HIV positive, the other was negative. And this was done in a couple of African countries. Next slide. All right. Basically, this is what we found with IREX. Found that Truvada was safe and effective in preventing HIV, and that it was effective in reducing overall the risk of HIV acquisition by 44%. I'm going to explain these numbers to you. 92% efficacy was correlated with high drug adherence. So I'm going to explain to you what that means. Next slide. All right. The 44% comes from everybody in that trial, the 2,500 people, everybody. All right? When they analyzed, they found that the people who actually took the drug and took it correctly, the reduction of acquisition was 92%. So you see, when we're given statistics, you got to look at the whole picture, what we call intent to treat, ITT, versus this basically a subpopulation. So if y'all understand the difference, basically, it works if you take it. The issue was that not everybody took it or took it correctly. That's where you see the differences in the numbers, 44 versus 92. Next slide. Lesson number 1. It works. Next slide. Partners PrEP. Now this was the stereodiscord in heterosexual couples, right?
At Team Friendly, we like to call that magnetic. Not so technical, is it? Sounds interesting. Because they're attracted to each other.
Okay. I'm sorry, but I'm going to use this.
I like it.
Okay. All right. So again, we see the same thing. All right. That there's a significant reduction in HIV acquisition. And now there were 3 arms in this study. 3 arms. We basically 3 groups in this study. One was with Truvada, the 2 medicines. One arm was just with tenofovir, and the other group was placebo. So what they found was, again, with the 2 drugs, 75% reduction. With the 1 drug, 67% reduction, which is still pretty darn good, right? Again, when they analyzed, and they did this by actually taking blood levels. Yes, we can actually take blood samples and see how much drug is in your system. And that's how they were able to determine who was truly adherent. That, and they had to bring in their pill bottles, etc., do pill counts, that kind of thing. So, detectable levels, those who had that, had a 90% reduction risk. Again, you see the big differences, right? In a tenofovir only group, and they also do great, 86% reduction. Next slide. The other phase of HIV/AIDS, African and African American women. Next slide. So basically, this is just a quick graph. I'm not going to go through the whole thing, but this is from the CDC, and basically this is a chart of the studies that I've already talked about, IPREX and Partners PrEP. They do include a couple, I'm just going to mention, PrEP, and there was another study called Voices with women. Failed utterly. Voices was stopped prematurely, actually. Why? They feel that, this was in Africa, I believe, right? One was a gel, tenofovir gel, and the other was Truvada. And the feeling was, or the thought is that, again, it was lack of adherence for whatever reason. Next slide. Oral tenofovir-based PrEP works when taken. Next slide. You tell me if he's positive, you tell me if he's negative. Maybe not, right? Next slide. Side effects and safety. We didn't see new side effects seen in HIV-negative individuals, which was a concern. We didn't. Common side effects reported with Truvada: diarrhea, nausea, abdominal pain, headaches, and weight loss. Typically, side effects like this, they don't affect everybody, and those that do tend to go away within the first month. It can cause kidney damage and loss of bone mineral density. This is the legal part. This is not the list of potential side effects. Next slide. But PrEP is expensive. How can I afford it? Truvada out of pocket is $8,000 to $12,000 a year, about $1,000 a month. And that's typical of HIV medication, by the way. That is not, unusual. So far what we're seeing in Georgia is that many insurance companies are covering it. It may require prior authorization and some hoops to go through, and I think some of the panelists are going to discuss that, but that's what we've seen. Patient assistance is also available via Gilead, and I think Olga may talk a little bit more about that. Next slide. How to start. Have a discussion with your doctor. All right, you have to be HIV negative. You cannot have flu-like symptoms, which may indicate HIV infection. The cost, contact your insurance company first. And not only do you have to figure in the cost of Truvada, you have to figure in the extra medical visits, about 3 to 4 times a year, co-pays, etc., and lab work. So those are the things that you need to be thinking about. Next slide. Contact Gilead for patient assistance. Take it every day. See your doc every 3 months to check HIV status and kidney and liver functions. Use condoms. Get support. All right.
4 minutes.
Frequent questions and concerns. I'm going to bring this up, but the panel's probably really going to be more talking about this. But these are the things that we're hearing. All right. Well, it's used to increase risky behavior and ultimately increase incidence of HIV transmission and STIs. So far, we haven't seen that. And the analysis of these clinical trials, so far, we haven't seen it. One other thing, just to mention, food for thought, there are gay men that never used condoms or used them intermittently. This is not new. So it's not that Truvada would cause that. This is something, a harm reduction technique. This is a non-judgmental harm reduction is really important. So if it gives them another tool to prevent a life-threatening illness, we should do that. All right, food for thought. Something we were discussing. It gives control to the user. So what if they're in a relationship with someone who is abusive or controlling, right? Particularly women. I know it happens with male couples also. But that gives control to that person taking it. So at least they can have some protection against that. Next slide. Well, non-adherence to taking Truvada increased incidence of drug-resistant HIV strains. I will let Dr. Kelly and Olga discuss that more, but we touched on that. One thing to consider, PrEP can also be an occasion for HIV-negative people to see their doctor more often and get more medical care than they normally would. And part of the PrEP strategy is to get not only tested for HIV, but other STIs. So in that sense, they're going to be getting more care. Next slide. Other concerns that I hear in the community. PrEP is just putting money into the pockets of pharmaceuticals. This response, by the way, the responses are by Mark King, who I contacted, and he allowed me to use his responses, which I thought were fabulous. HIV-negative people are just as important and worthy as HIV-positive people. You wouldn't tell someone who's HIV-positive not to take medication because it's putting money into the pockets of pharmaceutical companies, right? Gay men have expressed embarrassment and shame in taking PrEP as it was assumed they were barebacking and irresponsible and Truvada whores. I've heard that a lot. That's analogous to when the birth control pill came out in the 1960s. Women were accused of the same thing. Birth control, as critics have been saying since 1960, would be unnecessary if women only showed some restraint and thought. Great, I love this. Is the pill regarded as a license for promiscuity? Everyone knows what a pill is. It's a small object and its potential effect upon our society may be even more devastating than the nuclear bomb. That was what they were saying about the pill. Next slide. Again, basic HIV resources, references. Thank you very much. I'm now going to turn it over to our panel.
it even on? No, I don't think it. Thank you, Gail, for that. I know we did have one question, and before the panelists start, I want that question to be addressed. I believe it was River. Did you want me to ask your question? No?
River's in Tennessee.
Oh, River's in Tennessee. There was a question regarding your graph and whether or not the M-to-M population, if that graph included trans men. Do you know that? Whether or not?
I have no idea. It was from 2011. It was from the CDC. I do not know.
Okay.
Probably not. Do y'all have any thoughts on that?
Trans women? Yes.
No.
Trans men.
Trans men?
Probably not.
I wouldn't think so. I would doubt that.
I would say that the CDC is still being challenged to understand the transgender.
Yeah, transgender.
Most data I've seen separates MSM and trans. Generally, they're not combined into the same class.
Is there anyone from the CDC in the audience? They're in the front.
I'll take the time.
So with that, we're going to start our question portion. Just so everyone knows, we have people who are actually watching via the webcast. And for those people, thank you so much for joining us. If you have any questions, do them to ATL Prep at Team Friendly ATL. That's the hashtag, is ATL Prep. So I'm going to start with the first question going to Olga. What is proper protocol for being on PrEP therapy?
Well, I think you have to start. Having the conversation with your provider. So, if you feel that you are someone that is at risk, then you should go and visit your provider and have that conversation. It does require a prescription and it does require follow-up, and like it was presented, it's just one part of that, of all those tools that we have to prevent. We're not saying take this medication and forget about everything else. This is to be used in combination, and that's the indication, to be used in combination. But as we know, there are many people that are not using condom, and sometimes changing behavior takes time. So if that's the case, talk to your provider, and then you can make a decision. What we want to make sure, we want to emphasize is that person needs to be HIV negative. If there's any doubt that person could be seroconverting, then you hold on, wait a month, and repeat the testing. We do, there are many cases that are actually doing fourth generation HIV testing, where you actually measure for the antigen, or you could be doing viral load testing also, that will give you some guidance of someone that is having is called the acute, that doesn't have the antibodies. But there's still many places that are actually only doing antibodies. So again, if there's any doubt about acute or recent primary infection, then you should hold on and repeat the test in a month. There's a recommendation also that people need to be tested for hepatitis B. We want to make sure that we know the status. If people are negative in terms of antibodies, they should be vaccinated. If they decide to go on PrEP, they need to know that the medication does treat hepatitis B. So whenever that person, if at any point they choose to stop the medication, they should do it in combination and in consideration that the conversation should happen with the physician, because you might need to take some other medication. In terms of the protocol, again, once you make sure that person is negative, you can start the medication. The recommendation is that person has to come back every month and get retested. The provider cannot prescribe more than 90 days. The recommendation in the guidelines now asks for the creatinine. One thing that you have to make sure, there are few people that do have problems with the tenofovir and the kidney, so we have to make sure that they have an adequate kidney function before they start the medication, and the guidelines are saying to test people at 3 months, and then repeat testing every 6 months for kidney function. I think that one of the most important things about this, if we can remember that it requires, it's not only about prescribing a medication, but it's about educating people. It's about screening for STI, making sure that people are not acquiring sexually transmitted infections, and for those that to be treated. And we have to enforce continuously on a regular basis adherence. This medication does work, and it works in the 90% rate when the medication is taken on a daily basis. There's no recommendation at this point to use this medication intermittently. It has to be used daily, once a day, as long as you feel that you are at risk for taking the medication. So there's no limit of this medication. We're not saying you gotta take it for, I don't know, some people might take it for 6 months, some people might take it for a year, who knows. So as long as that person and the provider feel that they are at risk for HIV infection, then that's the indication to take the medication.
And just for our panelists, you'll notice this young gentleman in the front, he has a Mr. Friendly tablet. That gives you, for your opening response, we're giving you 3 minutes, and for your follow-up, we're giving you 9 seconds. So if he raises that, know that you're about 15 seconds out. A good follow-up question is going to be for Dr. Kelly. If approaching my doctor about PrEP, what questions should I ask?
I mean, I think the questions that you need to ask and to understand are whether you truly are at risk for HIV, and you may know that very well, but you may not know that. And your doctor should be able to help you work through that with some of the guidelines that have been given by CDC and other sites, whether you are at risk for HIV. And then from that, whether you're a good candidate. There are some people that are not good candidates for Truvada for PrEP for various reasons. They may have some medical conditions that make them not a good candidate to take PrEP. They have kidney disease or things, you cannot take PrEP. And so you should know about all the things that are reasons why you can't take it. Another reason is you're just really not good at taking medications. You may not remember to take your medicines every day. You know you're someone that is going to forget it half the time. That's probably not a good person to start PrEP. But there are other things you can do sometimes to work around that and to help yourself be a better medicine taker. But I think those are the things that you need to go to your doctor with those questions. Also side effects. And so if you experience some symptoms while you're taking the medication, is this something that's expected or unexpected? Is this something I should be worried or not worried about? How you should start it and when you should stop it are things that you should discuss with your provider. And I think also when, after you start it, how long before you should expect to be protected from PrEP is also something that you should understand as well when you are first starting the medication.
Anybody have a follow-up response on that? Okay. One of the questions that we've already had posted online was, will this drug affect fertility?
Not that we know.
Okay. That was easy. So this will go to both Lee and to Dylan. Have you experienced discrimination or stigma from the LGBT community or medical communities regarding your use of PrEP?
Well, let me start with acknowledging the fact that our partners at Emory Healthcare are spectacular. However, when it comes to discrimination from the medical community, I will also say that my situation doesn't arise from Emory Healthcare. I was admitted actually several weeks ago for something completely unrelated. I had a pre-existing GI issue that has absolutely nothing to do with Truvada or PrEP in any way. And I had managed to get strep, and I tried to swallow an antibiotic, and it got stuck in my esophagus. It was a pretty standard thing. I knew exactly what happened. I honestly just needed an endoscopy. So I went in, and the GI team did exactly what they needed to do and did an endoscopy. But my hospital medicine team, the first doctor that came in was looking at my medical history and said, "So you're on Truvada?" And I said, "Well, yes." And her response was, "Okay, so you've been exposed to HIV." So I saw this going downhill kind of immediately. And I tried to explain to her the difference between pre-exposure prophylaxis and post-exposure prophylaxis, and she continued to keep asking when I was exposed to HIV, how I was exposed to HIV, who I was exposed from. It was, it continued on from there. And like I said, I did have strep at the time, and any mother can diagnose strep. Strep always looks the exact same. It's a pretty basic condition. And so she rejected the fact that I had strep and said that since I was on Truvada, she wants to make sure that I don't just have HIV, gonorrhea, syphilis, herpes, or something else. Honestly, she ordered about 15 STI tests. I honestly think she pulled out a bulk of STIs and just ran as many tests as she could. Took about a week to get all of those back, and eventually I had somebody else from another medical team come in and say, "I'm not sure why they're ordering all those STI screens. It's strep, so we're just going to start treating that." So that continued for about a week, and it's one of those things where had I not been on Truvada and had she not noticed it, that situation probably wouldn't have arisen. But it turned into a week of, they put me on respiratory isolation because she had no idea what it was. She refused to look into it. It went downhill fast. And that's one of those things where it comes down to education. It is relatively new, as was said in the course at the beginning. It was approved in 2012. So not everybody knows about it in the general community, not everybody knows about it, not every doctor knows about it. So it's one of those things that comes down to education, and you need to make sure that not only is the general public educated on PrEP, but medical professionals as well that still do not quite know how to use, also get the education they need to make sure that they aren't unfairly discriminating or targeting patients that they probably should be looking at in a different light. Now when it comes to the LGBT community, recently, not really. There's never been a major issue in the LGBT community. They caught on to PrEP pretty quickly. There was the Truvada whore thing that started out about a year ago. That faded out pretty quickly because right as Truvada got popular, everybody really started talking about it. Facebook caught on. And I've never really experienced any major issues from the LGBT community.
One of the things that's very disheartening to me is to hear that Dylan had this experience so recently. I went on Truvada very shortly after it was approved by the CDC, so I understood that it was going to be a new and foreign drug. I had a fabulous relationship with my doctor at the time. It's the best doctor I've ever had. So I thought it was going to be easy, and I went in with a printout of the CDC guidelines for prescribing. And explained to him what it was and why I needed it. I was dating an HIV positive partner at the time, and asked him to read over the guidelines. And he immediately got very nervous and uncomfortable, said, "I'll have no problem writing that prescription for you," and walked out of the room without reading the guidelines, without seeing the testing that he needed to do before he prescribed it. One of the things that was mentioned earlier was that if there's any chance that someone might have been recently exposed and seroconverting, that one HIV test is not enough, another should be done. I had definitely had exposure risks at that time, and we just did one test, I got lucky, and I had to go to the nurse's station and tell the nurse the doctor left before I was done talking to him, and I have to talk to him some more. And he came back in and I'm like, "You have to do these tests." And then I begged for the hepatitis testing, and they would never do it. They said, "We don't do hepatitis testing here. You have the health department." When they gave me an STI screen, they gave me like a sample of 3 major STIs. And I'm like, "No, you have to test for everything." So it was kind of just a mess. And I wasn't automatically scheduled for the return HIV and creatine testing, and then when I called back a couple of months later, I was told that insurance would only cover my STI and HIV screening once a year because I was on HIV positive. And I'm like, I'm on a drug that requires this. I think you need to look into the insurance a little closer. The pharmacist that filled my prescription did not understand that I was on PrEP and not post-exposure prophylaxis, and insisted on giving me the entire sit-down in a private room discussion about post-exposure prophylaxis, which I was not on. And about halfway through, I had to shut up, stop trying to explain, and yeah, it's like, okay, let her say her speech. And then I actually also wound up in the hospital during the time that I was on PrEP, completely unrelated. And the doctor assumed that I was HIV positive because I was on Truvada, and I had to explain that. So my relationship with my doctor basically ended the day that I asked for PrEP, and it was always the thing. I never said anything was rude, but before it had always been warm and welcoming and open, and afterwards they were obviously comfortable with me. It was very hard to schedule appointments. So I haven't had any problem in the LGBT community, but definitely the medical community is nuts, and unfortunately it's still happening.
Thank you. We also have a question saying, and I'm going to direct this one to you, Dr. Kelly. My doctor doesn't feel as though I'm a proper candidate for PrEP. What is the proper candidate?
So I think Dale kind of outlined that very nicely in her presentation. So the proper candidate is someone who's truly at risk for HIV infection. And so that kind of falls into 3 categories. And so
men who have sex with men who are having multiple partners or having inconsistent condom use or who have been diagnosed with a sexually transmitted infection in the last 6 months or so, really, are appropriate candidates for PrEP. Anybody, man or woman, who has an HIV positive partner is also a candidate for PrEP. Women, the guidelines are very similar. So women who are having multiple sexual partners with inconsistent condom use, partners of unknown HIV status, or who have been diagnosed with sexually transmitted infection are also appropriate candidates for PrEP. And then finally, intravenous drug users who are sharing needles are appropriate candidates.
And then there was another question asking that, is it wrong for me to talk to a different doctor about PrEP other than my primary care physician?
Absolutely not, and you should. I'm not surprised that people will have stories such as the ones that we heard that are really just terrible and awful. But there are a lot of people, doctors included, who just aren't comfortable talking about sex and sexuality. That's the truth. And so if you find yourself in that situation, I think it's completely appropriate to ask for a referral to someone else. If they can't give you that, then you seek it out some other way. A lot of times, infectious disease and HIV providers are going to be who you get shuttled to, and that's fine too. We all realize that prevention is part of what we do and are all very willing to see people interested in PrEP. So that might be the first place for you to start if you find yourself in a situation where your primary care provider is not interested in helping you out.
Thank you. I'm going to direct this one to start with Jeff. Do you think with the implementation of the Affordable Care Act and its objective of helping ensure preventative measures for those with insurance, that PrEP should be covered similar to a flu shot?
Yeah, I definitely do believe that it should be covered. I think we're going to have a process to go through before we can get there. But again, as all of the medical presentations so far this evening have really stressed, Truvada is not something that every single person in the universe is going to be on. It's in some very specific cases. If we truly are going to realize the promise of the National AIDS Strategy and the AIDS-free generation and everything that we have been working so diligently for the last 30-some years, we're going to have to make sure that this tool is also accessible to people. And it is prevention, and prevention is clearly part of what is a cornerstone of the Affordable Care Act. Now, it doesn't mean it's going to happen overnight. It's going to take public pressure. It's going to take education and advocacy on behalf of the community, but also on behalf of the medical establishment to really call for this. I'm glad that Dylan and me shared your stories because I think it clearly shows exactly what part of the problem is. If we're talking about prevention, it's going to be more in the realm of primary care providers. And the knowledge base, the education, the understanding is just not there yet. And the whole system is going to have to work that people asking their primary care providers for this, primary care providers advocating to the insurance companies. We've got to have a stronger response from public health to really look at the benefits, both short-term and long-term, to individuals and to society, being able to dramatically reduce the HIV infection rates. But one of the statistics that I think we need to start talking about and shouting from the rooftops just here in Atlanta, there was a study that was released about a month ago that showed amongst young gay black men here in Atlanta, the annual HIV incident rate is 12.1%, which is one of the highest annual incident rates in any population in the resource-rich world, which means Atlanta is number one in the exact category we don't want to be number one in. And this, I think, is a clear indication that we've got to be more creative, with our approaches and more accepting of tools like PrEP that have been proven to work.
So a follow-up question for you, and I'll open this also to the whole panel. We are in the South. We do live in the Bible Belt. How do you think that our community at large can better engage those leaders, specifically those leaders with a large audience, to better address the issue of PrEP, since it is one of the only long-term chronic illnesses that is sexually transmitted?
Certainly, it begins by talking about it. We don't talk about HIV at all anymore. And we've got to talk about it. We've got to talk about it outside of the HIV circles that we travel in. In many ways, we've circled the wagons way too tightly. We've become really good experts on everything except being able to talk to the greater community about these issues. And so we've got to work on our own skills with that. It's always going to start with talking first to those elected officials and public health leaders that are going to be sympathetic, that need to be understood. I think the analogy that I believe was Dale in her presentation, talking about comparing this to the pill, I think that's a great way to begin the conversation with elected officials, health officials that are very supportive of women's access to reproductive prevention technologies. They're going to be, I think, more accepting and understanding of this. We've got to learn how to have some of those rich conversations. And then just keep the pressure on.
In following up on that, with Team Friendly, I've focused on working on education to reduce the stigma attached to HIV, which is now, we're also working on reducing the stigma attached to PrEP. One of the largest issues we see is the only community that seems to have a real and occasional daily conversation about HIV is the LGBT community. In order to reduce some of the stigma, some of the medical stigma in the community at large attached to PrEP, we have to make sure we can expand that conversation outside of just the LGBT community and to the heterosexual community and the various communities at large. LGBT members cannot be the only person discussing this medication. It helps more than that. It helps heterosexual couples and disparate relationships. And outside of that, to reduce the stigma and reduce the risks of, backlash about PrEP. I mean, you see people often who say PrEP, they're like, oh, so you're exposed to HIV. Oh, so you're promiscuous. Oh, so you're obviously having sex with when you eat. In order to reduce things like that, we need to make sure that even users that are not considered prime candidates, users or individuals that are not, even considering using the medication, still, if possible, have a base knowledge of what it is, so that you don't run into this constant issue of, oh, well, I went to my dentist office and they saw I was unsure about this, so they thought I had HIV. The conversation has to expand outside of just the LGBT community, and that's one of the largest issues we see, especially in the South.
Please.
Yes. As I mentioned in my introduction, I'm genderqueer, pansexual, polyamorous, and kinky. Sexual freedom advocacy is something that I've been involved in my whole life. The big problem is that outside of a monogamous sexual paradigm in America, anything else that you might be doing, no matter how responsible and ethical you are in your choices, is considered wrong. I was very lucky that when I went to my provider, I was able to say I have an HIV-positive partner, because that is something that you can't argue back against. Our general practitioners are supposed to be our gateway to prescribing, but really they are a locked gate. Because most of the reasons that you would want to be on PrEP, the comeback is, well, you should stop doing those things. You should stop, being an HIV drug user. You should stop, having sex with multiple people. You should stop your risk factors. You should not take this drug to make your lifestyle safer. Your lifestyle is wrong. Certainly in the case of, HIV drug users, yes, I would prefer to see them to be clean, but that's not so simple. And then when you come to the sexual issues, those are lifestyle choices, and we have the right to make our sexual lifestyle choices. And especially here in the South, where it's not just a lack of cultural exposure, it's also a very religious and moralistic judgment against alternative sexual lifestyles. really, it's not enough to say this is a fabulous drug and this works, because there's a huge segment of the population that believes that people who are living alternative sexual lifestyles, and to them the LGBT community is part of that, they don't believe that we deserve protection. So these two things have to go hand in hand. If we're going to say we have this wonderful drug that can help people who are living alternative sexual lifestyles who need protection, we have to also be saying alternative sexual lifestyles are valid and you don't have the right to make a moral judgment against them.
Thank you, Lee. Talking about one of the issues that is something related to the larger community as a whole, not just specifically an LGBT issue. Does PrEP prevent transmission of HIV to the fetus if a woman is on it and her becomes pregnant from her HIV partner?
Yes. I think if I'm understanding what you're saying, so if a woman is HIV negative and taking PrEP,
correct.
And her partner is HIV positive, and they and she becomes pregnant.
Correct.
Yes, presumably she would remain HIV negative if she's doing a good job taking her PrEP every single day, and the baby would also be protected. Is that the question?
Yep.
Yeah, because I think the point that we have to clarify is that the only reason the baby will become positive is if the mother is positive. So you know, there's this issue, and I'm going to expand a little bit on the guidelines. There's some comments. We don't have a lot of hard data, but there's the idea of people that are in serodiscordant couples and using Truvada around the time of conception. So the recommendation would be to use it 1 month before, 1 month after, and obviously time to the time that the woman is ovulating, and so you don't want to continue. But in the case that female was going to be at continuous risk of getting HIV, then the choice would be to explore continuous PrEP for that female, because if they only had unprotected sex for that time when she was trying to get pregnant, then you don't necessarily have to continue to use Truvada. But if the woman is continues to take chances, then that is a consideration. And we have to remember that actually, when you get pregnant, you're actually at a higher risk of getting HIV infected. That has been reported. So again, the only way the baby might be positive is if the mother acquires HIV.
One of our questions from online, and in about 10 minutes we're going to open up to people here. So if you do have a question you would like, as we're getting to that point, raise your hand, and one of our volunteers will send you an index card and a piece of paper so you can do it. One of our questions from online, and one of the questions that has already been brought up beforehand was, if you're on PrEP, and this will be started with our two panelists, and then I'll bring it over to Dr. Kelly, have you had to stop for some reason that was outside your control? What methods did you take? And the follow-up would be, what are the recommendations for if you have to or miss a dosage? Do you resume it immediately once you know, or do you stop?
I do know this applies to both myself and Lee after confirming there. Personally, yes, I have to stop for a short period of time, 1 month. At the beginning of the year, I switched insurance providers, and I switched from Aetna to Humana. On Aetna, I was paying nothing. My copay was $30. With Gilead copay assist, it was going down to 0. So it worked out fine. When I switched to Humana as my primary insurance provider at the beginning of the year, they classified it as tier 3, maybe for a drug which required 40% co-insurance. Came out to $498 a month after Gilead copay assist, came down to $298 a month. I did not have $298 that month, so it was one of those situations where I couldn't really, I couldn't get around that one. However, I did actually gain a secondary insurance company within the month following that, and my secondary came out at the same price as that month. So I discussed it with my doctor. We ran an HIV test just to make sure that my status hadn't changed. I had no exposures in the period that I was not taking medication, and prior while I still was taking medication. I had no exposures, took another test to make sure that status hadn't changed. and we start the medication back as normal.
I had insurance coverage when I started PrEP, and I will say that the one part of the experience that was extremely different for me, I've never had the first hiccup for my insurance. But I did have insurance coverage, and I'm currently unemployed, I'm self-employed and uninsured, and I will be able to get insurance through the Affordable Health Care Act when they start open enrollment this fall. But I am no longer with my HIV positive partner, so I don't know what kind of obstacles that I will face if I try to get back on Truvada. And an interesting thing, I don't have any health issues coming off of Truvada, but a lot of people say, oh, Truvada is going to encourage people to have more risky behavior. I did not experience that. My sexual behaviors did not really change while I was on Truvada. But after I lost my insurance coverage and was no longer able to have Truvada, there was just a feeling of, I guess, nakedness. You know, it's just, I had that protection and now I don't. And actually have severely curtailed my sex life. There are a lot of things that I don't feel safe as I used to. I don't feel safe as I was before I was on Truvada or while I was on Truvada. And so that's an impact that I don't think has been discussed before, so I thought I'd mention that.
Dr. Helen.
Shortly, if I may. I assume we're going to push later over side effects. In starting back after I was off for a month, I did experience minor side effects. Again, there will be a question about that later. However, I felt that should probably be attached to this as well. So that'll be covered a little bit more in a question later. But.
So I think people have gotten really sensitive about starting and stopping Truvada, mostly from our experience in treating HIV infection, because we're very strong about taking medications every day and not starting and stopping them with HIV infection, and that has to do a lot with resistance. With Truvada, yes, you need to take medication every day, but if you need to stop for a period of time for whatever reason, either you're not at risk or there's some other issue going on, it's okay. You can go ahead and stop that medication. Make sure you're protecting yourself for HIV for various other ways. But then it's fine to resume it at a later date. You need to have a conversation with your provider. You need to go through the testing that we're talking about just to ensure that in that time period you remain HIV negative. But that's okay. It's not the end of the world. If you miss a dose, you should take a dose as soon as you remember, to take it. You shouldn't double up though. So if you've missed a dose and it's time to take your next dose the next day, you should just, write that day off. But we really do want people to be taking it every day, to do a good job of remembering to take it every single day, and not missing doses. But if you have to, and if you do, it's not the end of the world.
Thank you.
The only comment that I have about this stop and start is on those guys or that are co-infected. I mean, they are infected with hepatitis B, and that would be an issue. That person needs to get with the primary care provider, and probably will require follow-up, and some of them will require medication to treat because we want to avoid flares. We haven't seen that, but we know the experience of people that are infected with HIV. Also, the guidelines are recommending that you do an HIV test after you stop the medication, and then again you want to do an HIV test before you start the medication again.
Yeah, I think just to say that one more time, if you also have hepatitis B, that's a different situation.
So Dylan kind of touched on it. What was it like taking a daily pill, coping with any side effects, incorporating this HIV prevention tool into your daily life? And did anything surprise you?
So, as far as taking a daily pill, I have had acid reflux for a long time, so I've been on a daily Nexium for years. At the time I started, I wasn't. But it's a matter of, honestly, I just leave the bottle of Truvada sitting on my nightstand, and when I regularly lay it down, I take it, because I always have a glass of water on my nightstand. So for me, taking a daily pill, it wasn't a major concern. When I'm traveling, it throws my rhythm off a bit, because my nightstand is kind of like my reminder to take medication. So some of those things, you have to build yourself a rhythm, and you get a month or two into it, taking it to build, you get to the point where it's a natural, kind of muscle memory situation. As far as side effects are concerned, honestly, pretty minor. I experienced some minor nausea and an upset stomach for about a week, and then those kind of just faded off. The only side effect that did continue is there is the risk for elevated liver enzymes. That is every 3 months, like they said, you'll do a follow-up appointment with your doctor, who will run a metabolic panel and also an HIV test, and a STI test. My liver enzymes are elevated, specifically AST is at 50, ALT is at 65, and there is a major concern, and it's one of those things the doctor monitors every 3 months. Should there become an issue, it will be addressed, but to my knowledge, the studies have not shown a serious issue regarding the liver enzymes. And I do believe they've also shown once you stop use, those also return to normal levels.
Okay. So actually, there was no difference between placebo and the group of people that were taking medication in terms of liver function tests. So the one that you might be referring is to elevation in kidney function, creatinine, and those, for the most part, if the client was going to experience that once we stop the medication, it actually increases.
My biggest worry with going on PrEP with side effects, I am a notoriously bad medicine taker. Normally, if there can be a side effect, I will have it. So going on something long-term was definitely a concern for me. But given my situation, I was like, I'll tolerate whatever side effects come along. I was very surprised. I had dry mouth for about 2 weeks, and that went away, and it was the only side effect that I ever had. During the first month, I missed a handful of doses, and nobody could tell me what the right protocol was, so I just went ahead and doubled up on my dose, like put it down with a birth control pill. And then later on, I kind of got the information that it does stay in your system 72 hours. And but after the first month, I got in the rhythm of taking it every day. And I think understanding, for me, I read all the studies, and so understanding the difference that adherence makes was very instrumental in me taking that adherence very seriously. Even when I take antibiotics, I'm like, yeah, whatever. But not with PrEP, because I understand that I'm looking at the difference between a 44% prevention rate or a 92% prevention rate. So that was a very big factor in me taking that daily pill very serious.
And I will say about what she said, having read the studies and knowing the difference between adherence and I'll just take it when I need to, it's one of those things, like I can tell you in the first 3 months I missed 4 pills. I can tell you after I've taken it, after I started back, I missed 1 pill. I kind of got OCD on making sure I never miss a pill, and then I miss a pill, and it's a day of beating myself up and getting back to the next day, trying to get back to the rhythm. So knowing those studies and knowing the difference between high adherence infections and not high adherence really kind of gives you a better insight and a little bit more motivation to make sure you are taking it on that regular basis.
So one of our questions from the audience, this is for the medical professionals. Define multiple partners. If someone is constantly using condoms, how many Grindr hookups are you having before you become a good Truvada PrEP candidate? I think the emphasis is how many partners would make you a candidate for PrEP?
I mean, I think it depends who you are and who your partners are, and what the kind of, we say, HIV prevalence is within that kind of network of partners. So I think when the CDC published their guidelines, they had this risk tool that you can find online now to tell you how many partners that might be, but I don't know that I like as much making such a delineation, because I think there's a lot of gray area, because it only takes that one partner, right, that one special partner to be exposed to HIV. So I don't know that there is a good hard and fast rule. I think that if you are having sex without condoms, either inconsistent or not at all, with someone that you are not fully confident in their HIV status, then you're a good PrEP candidate. No matter if that's one person or 20.
I agree. I mean, I think that you have to take into consideration that person, the person they're having sex, the area where they live, and it just takes one act to get infected.
So this is going to be for both Jeff as well as the whole panel. The community is already dealing with prevention fatigue. Now we're dealing with treatment and treatment fatigue. Are we not talking enough, or are people just tired of hearing, and how do we deal with this?
I'm so glad you taught me this. You know, I don't, to be honest with you, there is no good answer to that. If I knew what the answer was, we would be doing this. Why is this room not full of people? Frankly. Why do we not know? I'm guessing that for a lot of folks in the room tonight, we saw the slide up there about the infection rates. And looked at it so much higher amongst gay, bisexual, and other men who have sex with men than other risk groups. I'm guessing that there were a couple of people in this room who were kind of surprised at that. And so there is a lot of fatigue that goes on. There are a lot of people, and unfortunately a lot of people in positions of power and authority who honestly believe that the HIV epidemic has been taken care of here in the United States. That that's that problem in Africa now, right? And so in many ways, we've got to restart the conversations. I honestly think we've got some good tools at our disposal to restart some of those conversations. And frankly, that's what's going on in pop culture right now. As much as I really hate to admit how old I am and what a dinosaur I am, the fact that The Normal Heart is coming out on HBO, the fact that last year was all about these ACT-UP documentaries. There's a lot going on in pop culture right now that's looking back to the early days of the epidemic. And I think we are smart enough. We've got to seize that opportunity. We've got a small window right now to look at those stories and then our commentary. That's the world of the past. But it gives us lessons to move forward in the future. I think that, frankly, if Lee talking about sexual diversity, alternative sexual lifestyle, sexual diversity, it is a challenge here in the South. It's a challenge, frankly, everywhere in the country. I think we need to put pressure, frankly, back on the LGBT organizations to reclaim HIV. For 20 years, we have been very intentional about pointing out that HIV did not equal gay. There were really good, solid, important reasons that we did that. But then what got lost is that it began to believe that HIV didn't have anything to do with the LGBT things. I spent a lot of time with my colleagues around the country with other state equality groups, letting them know that HIV must be on their radar. There's a lot of policy work, there's a lot of work that we need to be doing. And so I think that's how we begin some of those conversations.
I just have a comment. I think that people are less scared about HIV. The therapies, they're simpler, they're very effective, we're able to get people to non-detectable, if we start therapy early, they're able to live almost a normal lifespan. So when I talk to groups, especially to younger people, it's almost like at some point it's gonna happen, so let's just get it done. When you talk to someone that is older, they are more scared because they have less access to all this information about therapies. So I think that's one issue that might affect the fact of prevention and the fact that we have all these therapies available, and people have forgotten how sick people got with HIV. Those of us that were there taking care of people 20 years ago, and 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 the same way they forget about prevention in many other conditions. I mean, this is not only about HIV. I think to some extent, this might actually motivate in other areas of medicine that we start doing with more and more, even with the HIV infected clients that we're seeing. But I think the responsibility is on everyone. We have, like I said before, there's very few people that have the passion and the interest to move this forward. And I think the approval of this, the release of the guidelines is a great opportunity to spread this message and try to get as much as you can out of it. Because I don't think in terms of basically just HIV, people are pretty complex. And I heard someone saying HIV is not a death sentence any longer, but it is a life sentence. And because it is a life sentence, we need to do as much as we can to try to prevent infections. Obviously, it doesn't kill the same number of people that it used to before, but it still kills 16,000 people every year in the US. So we have to do as much as we can to therapy. That is a very good way of preventing HIV, treating all of those. We should not, this is about PrEP, but we should not forget that one of the best ways of preventing transmission of HIV is actually treating those that are infected and getting them to non-detectable viruses.
Real quick, if I may, tying off what both of them said, she mentioned that there are a lot of people that have gotten complacent about HIV, and it's true. The conversation has died out in quite a few communities, and it has died out to a large extent in the LGBT community. I can say on multiple occasions, I have heard gay males between generally 18 and 25 say in nearly direct quotes to me, well, you know, it's fine, you can treat it now, so I'll just go ahead and get it. And there's a large feeling of, well, we can treat it now, it's not a big deal. And the conversation died out to a point that a lot of people don't understand. It is still, you know, $8,000 to occasionally $20,000 a year to afford HIV medication. There are still side effects. It's not, it still exists, it is still a problem, and it is still something that needs to be discussed. So the fact that treatment regimens do exist doesn't mean that we need to stop discussing it. It doesn't mean that we need to pretend it's not an issue anymore. Which is why not only is PrEP, not only does PrEP have to be a conversation, especially when we're discussing your prevention methods, especially when we're discussing your risks. But as she said, effective treatment is a massive. Does reduce the risk of transmission massively. So not only does PrEP have to be in the conversation, but treatment, early treatment, and effective treatment has to be in the conversation as well.
I have 2 points I'm going to tie together at the end. The question talked about this conversation fatigue within the community. And I think the problem is that we're really only having this conversation within the community. And I do understand, we saw the charts where, you know, obviously the male-to-male transmission rates are astronomically higher than any other category. And the problem is that we're a very small subculture, you know, when you look at the overall demographics of the United States, and we're only having this conversation within our subculture, and we're not leveraging, like you were talking about, you know, we're finally breaking into the mainstream media with LGBT representation, etc., and we're not really leveraging that to talk about HIV like the way we are to talk about marriage and these types of things. So that's point 1. Point 2, I want to talk a little bit about bisexuals. On the LGBTQ spectrum, the bisexuals are invisible. I almost exclusively date bisexual men. And they're very closeted. The older I get, the less I'm willing to put up with closeted men, but they're so closeted. So they aren't part of the conversation. Even though they are part of our community, they're not participating in it. They're not listening. And the only way you're going to reach them is through the mainstream media. If the larger straight community is not talking about the fact of, oh my gosh, we have found an effective preventative, then they're not going to get a message. And this is, especially the male bisexual, incredibly large contingent. You would not believe how many men are bisexual. You would not believe how many of them are out there on Grindr, on Craigslist, going home to their wives later on. I have a mountain of toasters, and it's just, it's what it is, and that is in the male-to-male, really out and gay population. We are talking to each other, and there is this accountability, but you've got this invisible community where it is not, and it's practices that even in the gay community, if people are bareback, they're very out about it. You have that conversation. In the male-to-male bisexual community, and it is vast, none of this education is happening. None of this communication is happening. It's still Wild West out there. You're not going to reach them unless you see this as mainstream media.
Thank you. One of the questions we've had submitted as well is, can PrEP result in a false positive reading for HIV rapid testing screening? And does PrEP, can it result in resistance to Truvada?
The only way you will get resistant to Truvada is if that person becomes infected. The virus becomes resistant to Truvada or any of the components, not the person. So you will need to get infected with HIV to become resistant to any of the components of Truvada. The good things of all these studies is that none of the people that became infected actually develop any resistance. But those people, remember, these are bigger studies than after all the demo studies, and they are being analyzed now for the people that might have acquired the infection. But the people that became infected after they were put on medication didn't acquire any resistance. The people that did acquire some resistance, and those were very few cases, were the people that were missed because they had an antibody test and they were actually seroconverting at that point, and they were based on the medication. And most of the resistance was seen to FTC or MPC-tabine, so with the 184. But I don't remember what was. Oh, no, there's no false positive.
Okay. From one of our audience members, for serious diabetic couples where one partner is HIV positive and one partner is HIV negative and takes Truvada, what is the success rate when no other preventative measures are taken, specifically condoms?
Well, I mean, you have.
Excuse me, that was my question, and you left out the part about the HIV person is undetectable.
Sorry.
The HIV positive person is undetectable, and they're in a relationship with an HIV negative.
Mm-hmm.
And we saw 92% on the screen. So I wondered if you had a different percentage.
Yeah. So let me talk about that person that is positive, that is on therapy, that is undetectable. We have HPTN 052 that show 96% protection. And then we have recently the partner study that actually there was zero transmission from people that were non-detectable. So that's what I said, getting people to non-detectable is a very good way to prevent transmission of HIV into the community. What we see here is that, and remember that these studies are done in conjunction, all these people were recommended to use condoms to go and get screened for STI. So I cannot tell you what is the percent of protection if people are not using condoms, because the studies were not designed for people not to use condoms. It was unethical. So both groups were recommended to use condoms. We do know a bunch of people didn't use condoms because we saw in partners, we saw women getting pregnant, and the CDC there were a number of pregnancy also. So a lot of people actually, and we saw multiple STIs also in these studies. So we do know that people didn't use condoms, but based on data, we cannot say that the level of protection of this if you don't use condoms. I can tell you that none of the studies have shown that Truvada is 100% protective. And because of that, we recommend that you use it in conjunction with condoms.
And if I could add just one thing to it, again, I don't know that people understand, and maybe everybody does, but I spend a lot of time worrying about the fact that the rates of people who know their status, that are seeking medical care, that are on antiretrovirals, that even then, the percentage of people that achieve viral suppression is alarmingly low. And so there's a lot of complicated issues that are at work here, but I do think that it's important to just keep that in mind, that even with all of the perfect factors, we still end up with maybe only a third of people that are actually in medical care and on antiretrovirals that achieve viral suppression. So there's a lot of challenges still ahead of us.
I think it's also important to note, and I believe both of you can tie off to this, not every undetectable is the same. There are multiple tests, so undetectable does not always mean the same thing. There's different viral floor for different tests, which mean one test might not be able to detect under 300, one test might be able to test under 50 for the viral load. So there are variations thereof, but I will say that even in the packaging for Truvada, the little label that Gilead sends you does say in big bold letters, this is to be used in combination with safer sex practices. So the official recommendation is, of course, to seek safer sex practices on top of it, because it also does not prevent from STIs other than HIV.
Yeah, so again, one of the reasons is because that's the way the studies were designed. Non-detectable is non-detectable. So it is likely that someone that is less than 200, if we run it in a one that is less than 48, will be non-detectable. So the issue with that is being consistent for the most part, and with time, the tests have become more sensitive, and that's why we can get to these very low rates of detecting HIV. My issue is the fact that at times there might be something going on with that person. If they have a sexually transmitted infection, there might be some discordance in terms of viral loads from the blood to the semen, and so more than the issue that not every non-detectable
I think that that's a really tough question, and it's not the kind of question that you can answer on a panel to a room of people. I see plenty of couples that are in monogamous relationships where one person has HIV and is undetectable and the other does not. And that's a conversation you have in the room with your provider and that couple, understanding all the risks and the data, and that couple can make their decisions based on that. But there's no blanket answer for everyone to say that this is right or this is wrong, or it's going to be 90% or it's going to be 65%. I think it's understanding that individual couple situation, what the risks are from the data that we know, and what that couple chooses to do with their sex life.
Question that we've been asked from the audience, I'm going to expand on it a little. The biggest concern / stigma associated with PrEP. And with that, I'll ask both of our first-hand experience users, Dylan and Lee, what were your biggest concerns and what were some of the biggest stigmas or prejudices you faced? And then to our medical and to Jeff as well. And within the medical community, what do you think are some of the biggest misconceptions and some of the biggest hurdles that, as a profession, they have to deal with?
I've already touched on just the ignorance in the medical community and some of the moral prejudice, and so I'm not going to repeat those things. The biggest stigma that I run into with PrEP is the serosorting myth. People believe that serosorting is an effective HIV prevention strategy. And I have to admit that even despite a lifetime of being immersed in safe sex education and teaching it, I was 25 before I really got it. The first time that I considered having sex with an HIV positive man, we got right up to the deed, and we were discussing things, and I said, so what precautions do you take to protect your partners? And he said, well, that's your responsibility, that's up to you. And I said, well, I need to think about that. Let's get back together. And I went to talk to my girlfriend at the time, who was a sex educator, and I'm like, so I know all about safe sex. I said that if I'm going to have sex with someone who's HIV positive, what extra precautions should I take? And we were at a restaurant, and I could just see her like restraining herself. It was all she could do, you know, like slide inside the head and walk out. And the answer she said to me is, if you aren't having sex with everyone as if they have everything, there's no point in having safe sex. But unfortunately, wide and large, that is what people think, is that you seroquel. And that is how to keep from getting HIV. You do not have sex with anybody who has HIV or might be at risk for HIV, and that is how you keep yourself safe, and that is the first line of defense. So when they hear that I'm on PrEP, they'll think, oh my gosh, this is this wildly reckless person who is exposing themselves and then myself by proxy to HIV. And the serosorting myth is the largest stigma that I've seen attached to PrEP and safe sex in general.
So as far as stigma from the medical community, that's already been addressed. I'm not going to repeat those. Feel free to find me after if you did miss that part and you do want to hear some side stories. It's hard to say whether it's stigma, but as far as things that changed with the use of PrEP, I am very public about my use of PrEP. I will discuss it anytime, anywhere, and at the time I'm not on all of the apps, but when I was on the apps, they all blatantly said it. And one thing that I did notice is on multiple occasions, when it was mentioned that I used PrEP, the conversation switched from, oh, well, I practice safe sex, to, oh, well, you're on PrEP, why do we need to do that? I had multiple guys go, oh, well, we don't need condoms. Yes, but you're on PrEP. That's not how this. He's like, well, I'm on PrEP too. I'm sorry, that's still not how this works. And on multiple occasions, there's this, well, you're on PrEP, we don't need practice safer sex. So you're on PrEP, it's not a big deal. So that a lot of that is the fluctuation with education, and you're going to get different responses from different people. As far as stigma is concerned, there hasn't been a large amount of stigma. As far as non-LGBT community, every now and then there's that, oh, so you have HIV, or oh, so you've been exposed to HIV, and it comes down to a matter of explaining the difference between post-exposure prophylaxis and pre-exposure prophylaxis. And as far as concerns, I guess I can't say I had that many concerns going on. I read the studies and I was pretty familiar with the data at the time. The only real concern was if I had a change in insurance and I had an issue, what would my situation be if I had to come off? But that was addressed, of course, when I had to cope with that issue, and it ended up not really being a large concern. So I don't.
Again, it's ignorance, but I think it's ignorance in some different ways. So, concrete example of this. I serve on the Jurisdictional HIV Prevention Planning Group, which is a new body here for Fulton and DeKalb counties. And I'm actually, I look at their comprehensive plan. And this was written in 2012, which explains parts of it, but PrEP was not even included. And when this got brought up a few months ago, the response from the officials at the health department were, well, we don't even know we can include this. We're going to have to go seek permission from the CDC, because we don't know that we can include PrEP in this. And then there's a lot of confusion between PrEP and PEP. They still don't quite get it. And frankly, these are the folks that are now in charge of prevention efforts here in Fulton and DeKalb County because of our high incidence. And it's troubling. And it's not necessarily that these people have the stigma and they're against it. It's just something new and different for them. And so they are literally spending hundreds of thousands of dollars a year distributing condoms and not even having a single conversation about PrEP. And so there's some ignorance that needs to be overcome there. And my guess would be, if we looked at the companion prevention group that is run by the state of Georgia, that we're going to have similar attitudes there. And some of that is rooted in the fact that just historically, for better or worse, it just is what it is, that in the world of HIV, prevention has been in one silo, treatment and care has been in another. And there's a lot of understanding about treatment as prevention, and there's a lot of attention there, but we're still not looking, I think when we look at prevention, we still look in the world of condoms and clean needles, and we've got to get beyond that.
I agree with all of the comments here. I think that my first impression with this, because I was one of the first ones talking, going to the different cities, is that most people focus on the barriers. So they didn't even want to hear about it. So it was a challenge to present this data. And I wanted to start with the health education, at least for them to have an idea. I don't know that any of these places needed the permission. There was some guidance already from the CDC, but those were the issues that came out. Again, everything was a barrier here, cost, fees, who's going to do this. I could hardly find anyone that will see this as something that we can work on. And I work on the South, so that's what I said. I mostly live in Miami, and it's up to now that they are also moving, trying to do something, because the focus was always on the barriers. I'm one of those that believe that there's as much stigma in prevention as it is in people that are HIV infected. And one of the reasons that boys and FemPrep fail was because of the stigma associated, these females being seen taking a medication that they will mean to other people that they are taking something because they could be exposed or have HIV. So we, stigma is still present there, and we're gonna have to deal with it. Again, I do believe that that education is needed. That the clients are going to have to request from the providers to get educated about this. It's going to be very difficult. We can talk about media and this and trying to get, but it's going to be people getting educated about this and then going and requesting from their primary care provider, I want this, or I think I should be on this, I want to discuss about. And hopefully, like I said, this is the best opportunity now that the guidelines came around, and it might move people to get oriented. And I also think that one of, going back into what you were saying about media and all that stuff, is that we have to find an opportunity to get into primary care conferences, because the IDs and the people that have been doing HIV are very familiarized with these concepts, and they're not scared of these medications. And so there's the scare of the medication and the scare of these people having to be followed up and all that stuff. So if we could get more of this information into primary care conference, because we continue to preach the choir. So these are mostly the people that are already interested and know, and we're not getting to those that don't have the information.
Lee, do you have a final?
I would like to do a quick follow-up to what I was saying before prescription. I realized that when I was talking about stigma earlier, I was talking about the serotonin myth, and I didn't actually talk about what that is. As a safe-sex educator, the thing that we run into the most is the serotonin myth, and it is the idea that STDs do not happen to good people. I am a good person, so I will not get an STD. I don't associate with good people, so I will not get an STD. I will be able to recognize one of those bad people that might have an STD, and I, of course, wouldn't have anything to do with those people, so I am safe. And when you say I'm on PrEP, it breaks the serotonin. Suddenly, you get lumped into, oh my gosh, you aren't following the rules. You're willing to associate with bad people. And the reason it is a myth is because there is no way that you can really know anybody's status. Even the most educated people who are tested regularly, we have windows where we can only say, I probably don't have HIV. And then you get to with people who are less educated or think, you know, I've been tested sometime in the last 18 months, and that means that I know my status, you know, and they're telling you the answers to the best of their abilities, but they don't know. You know, and you think you're looking at somebody fringe robber, you have no idea what they're doing behind closed doors that you don't know about. Sera sorting does not work, and that is the big thing in sex ed, you know, in safe sex that we're trying to teach people. So, you know, that's a major area of stigma is until we break the Sera sorting myth, we're always going to deal with stigma with any profession.
And if I may very quickly, on concerns, I just realized that it didn't directly apply to me, but I have heard this concern from multiple people. One of the concerns echoed often from individuals that are seeking PrEP is getting it. Just the sheer fact of discussing it with their primary care physician. And a lot of that comes from these continued stories of primary care physicians having no idea what it is. And, you know, I had one friend that went to his doctor, and his doctor told him if you took PrEP, there's no way you could ever get HIV. You know, so a lot of the concern that many people have is actually getting it. I will say personally, I didn't have that concern because I do know that one of my primary care physicians, he specifically does practice in HIV treatment and work with the LGBT community specifically, so I knew that he was educated on the matter and I knew I wouldn't have any issues. And as she mentioned also, most infectious disease doctors who have been working in HIV are also relatively knowledgeable in the situation. However, I do know one of the largest concerns I've seen from the community is just the sheer having the conversation with your doctor and not knowing how they're going to respond.
On the heels of the article that came out from the CDC as well as on the New York Times, and I'm going to pose this to Jeff, but as well as to Dr. Kelly. What are your views on Michael Kleinstein's party drug comments and his opposition to the CDC?
Georgia Quality, I'm proud to say, was one of 68 organizations, along with the Research Consortium of Atlanta and Sister Love here in Atlanta as well. There may have been some other Atlanta groups, but the three of us that I know signed on to a public statement that PrEP is important. We applauded the CDC for releasing these guidelines, and we condemn Michael Kleinstein with his views. So I'm already on the record with that. I think that again, part of what I said at the beginning, that 5 years ago, I really was a bit of a dinosaur. The studies were starting to come out. I was having some concerns at that point in time. I think what you had said about the barriers. I was looking just at the barriers. And I was not looking at the promise. I was not looking at the hope. I was not looking at the possibilities. Once I overcame that, it's like, wow, this really can be an exciting time. When I overcame my own prejudices and recognized that this is harm reduction, and I have always proudly espoused harm reduction. This is no different than advocating for syringe exchange programs, to advocate for Truvada. It's another tool in the toolbox, and it could actually get us beyond the HIV epidemic that we really thought we would be looking at the rearview mirror. And it's still here, it's still very much a part of it. So I think it really is kind of also putting that positive spin on it. That's how you kind of overcome the ignorance and the stigma. I remember in '96 when protease inhibitors first came on the market, my program didn't want to pay for it because, well, new drugs come and go, this is the latest flash in the pan, 6 months from now we'll realize that they're not as great as you think they are. And then the next barrier was that they cost tens of thousands of dollars a year. The public health system will never be able to afford that. And then it was that injection drug users and people with low incomes will never be able to understand the complications of taking these multi-drug regimens every single day, and will build viral resistance, and we'll have super strains of HIV that will just wipe out populations. Like Godzilla. None of those things tend to happen. And again, it was the public, it was the patients that drove those conversations by going to their providers and saying, we've got to have access to this. don't fall into the misstatements and the myths and the misunderstanding. And when I said earlier that we've still got a lot of work to do, antiretroviral medications, combination therapy, the cocktails, 96 by the time we had hit 2000 it was standard care. So when I say we've got a lot of hard work, that doesn't mean that I'm talking decades from now. But I am saying that over the next couple of years we have to do this, and it's us who has to do this.
Dr. Kelly?
Real quick, I will also say that Team Friendly and I also strongly condemn Dr. Feinstein's views. It is not an friendly approach to start saying that an entire class of individuals that are just looking to enhance their prevention regimen and enhance their personal health regimen, are just seeking to party or just, wanting to, go off and be sexually promiscuous with every person they run into on the street. In no way is that an friendly approach, and in no way is that an appropriate way to respond to what could be such an important tool to the health programs for so many individuals.
I think for me it's just incredibly simple. If there is an effective prevention method, people should be able to use it. And that's period. We also have heard a lot about the promise of PrEP, and I think we also need to understand that we're at the very beginning of PrEP. And PrEP is going to evolve over the next years, over the next 5 to 10 years. There are things coming down the pipeline that are even better than what we're talking about now. And as these things come to market, longer-acting agents that you may not have to take every day, things are really going to get exciting then. And I think we all have to stay tuned, keep ourselves educated, and watch very closely, and be able to pounce when those things are ready for us.
Although I know we've kind of covered this question, I am going to ask it very specifically because it's been asked 2 different ways from people, as well as it was one that we had on our list of pre-asked questions. Does PrEP guard against any other STIs, or is PrEP only specific to HIV?
The only other sexually transmitted infection that PrEP is probably effective for is hepatitis B that we've talked about. Otherwise, it does not protect you against herpes, syphilis, gonorrhea, chlamydia, the long list of other things that are out there. And that's why condoms are still an important part of your prevention regimen.
Actually, we do have the data about hepatitis B. The studies have been done, and it's not 100% protection for the reduction. But I don't have anything to add.
Oh, and in Georgia, we're also close to #1 for syphilis and gonorrhea. So don't forget that.
One thing, it certainly is not, to my understanding, and the medical professionals on the board maybe can speak to this better than I can. It's not widespread, but we are beginning to see drug-resistant strains of syphilis and gonorrhea. Some people look at the list of things that PrEP doesn't cover, and they're like, well, I can treat all of that with a pill. Those are all temporary infections, whereas syphilis and gonorrhea are becoming much more serious and will continue to become so in the future.
So this was just asked via YouTube. What problems or concerns do you, the panelists, have in reference to PrEP with the potentially new director of the Georgia Public Health Department and his anti-gay statement?
I think that there's a little bit of clarification on that. First of all, it's not the director of the Georgia Public Health Department. It is there are health districts throughout the state, and this is one particular health district. And then the important thing here is that hire has not been finalized. I think that so I said something bad about Michael Feinstein. I'll say something good about him. He actually, AIDS Healthcare Foundation and Michael Health, because they are based in California, they were familiar with him. They actually were the group that alerted many of us that this was going on. It had great coverage in the Atlanta Journal-Constitution, Georgia Voice, The word got out today. We're going to be monitoring the situation very, very closely over the next couple of days to see what the Department of Public Health actually does with this. But they have been quick to point out that the hire has not been finalized. But I do think that this is an example of why we really need to be vigilant all the time. Because it's one person that his bad attitude really could have caused significant problems for an entire region of the state. It was the Northeast Health District up in the northeast corner of the state, Rome. And if this guy had come in, if this hadn't come to mind, I think he probably would have begun to suddenly institute some negative policies, or at the very least, I think that the chances would have been good that he may have been even more reluctant to institute some of the good policies that we need to see instituted.
And piggybacking on that, as you said, again, the hire is not finalized. Much like we saw in House Bill 223, the similar Senate bill, which would have been the Religious Freedom Acts, with Georgia Equality's help, with Lemon Legal's help, and with the LGBT community in Atlanta as a large. We protested, we went to the House, we sat in on the bills, and it was made very clear that the community did not support this decision. You're seeing a similar thing here. The AJC has very heavily covered it. Georgia Equality, the other organizations have very heavily covered this situation at hand. And since that hire is not finalized, with the community support and with the community expressing their disdain for the situation and their concern with the situation, decisions do change, especially with hire decisions like that. So as long as the community does express their opinion and audibly regarding the situation, that decision still can change, and we have seen similar decisions change historically.
We've kind of talked about it briefly, but one of the questions also asked was, how do we better approach mainstream or traditional media? As you know, one of the people who put this on, I can tell you that we had support from the Georgia Voice, one of our huge allies, and we're very happy to see that WABE is here as well. But how do we reach those organizations, in your view, that are the more traditional mainstream in regards to PrEP?
So, given my history in communications, it's a lot of things are just on how much you say them. So when we target this all from a lot of the times we see PrEP discussed, and a lot of the time we see HIV discussed, it's very heavily targeted at just men who have sex with men. We have to change that in order to get to the broader, heterosexual community. We have to make sure that we are discussing that HIV does affect the heterosexual community. It does affect women. It does affect non-LGBT members. If that is not discussed and if that is not included in the conversation, then you're never really going to see an expansion outside. It's very hard to get people to discuss and understand a situation when it doesn't apply to them. Personally, in my other organizations, I know it's nearly impossible to get funding for refugee camps, especially from Americans, because they don't see it. It's not near them. You're not related to the issue. You're not directly attached to the issue. There's such a disconnect that often people are reluctant to either listen or understand or comprehend a situation. So we have to make sure that we are discussing that heterosexuals are affected, that women are affected, so that we can make sure this discussion is had by every community that can address. And it can address, it can be much a more far-reaching, support mechanism than it is to just men who have sex with men. And I think that is a large part of the situation. Is we have to make sure that the whole conversation is discussed, not just a tiny segment.
One thing that I mentioned is that pretty much my whole sexually active life I've been paying attention, waiting for the cure for AIDS. And every story that ever comes out, it's like, oh, there's going to be a vaccine, or there's going to be this, or there's going to be that. And then you read the article and they say, maybe in 10 years. And 10 years later, it still isn't the case. I think that there has to be something, some verbiage that distinguishes Truvada, that says this is not in the pipeline, this is not some dream 10 years down the road. And like when probicides were discussed, they had such low efficacy rates that they just weren't practical. And so I think that in order for the mainstream to wake up and realize it's here, that some sort of different verbiage has to be used than what we have fatigued everyone with. We've cried wolf so many times. We've got, so there's a cure coming, there's a vaccine coming, there's a preventative coming, that I think people aren't listening now.
And then, although we have discussed PrEP, one of the questions that came up was, what are the options for PrEP?
There's really only one option right now, and that is that's FDA approved, and that is Truvada, which is the combination of tenofovir and emtricitabine into a single 1 pill once a day regimen. Some of the clinical trials also showed efficacy of just tenofovir by itself, but I don't really see any benefit in using tenofovir by itself when it's, Truvada is already combined into 1 pill once a day, and that's what we have, some indication of the best efficacy rate. So right now, that's it. But there will be other things in the future.
So the only drug that should be used in the MSM population is the combination of Truvada. You might consider using tenofovir by itself for heterosexuals or IVD use. Because this was actually the Bangkok study that was the one that looked at IVD use was done with Gilead. But if we're talking about MSM, it's only Truvada. I mean, and some people might consider, because there might be a difference in cost. Two drugs, Gilead versus Truvada. So, but I think to make it easier, as we're dealing with providers that are so fully aware, we leave it as Truvada. But if you read the guidelines, there's a commentary there on the you could consider Gilead in some specific situations, or tenofovir, like so.
At this time, we are about 10 minutes away from 9 o'clock, our closing time, so I would like to go ahead and close the open portion of questions and say thank you to our panelists. Your information, your honesty to our firsthand experience, as well as your willingness to come and talk to us has been inspiring. And we hope that this is only the beginning of a much larger conversation, not only within our community, but within the Atlanta area. So thank you. I'm going to introduce Mark, who is with the Hope Clinic, who is going to talk about some of the opportunities for people who might be interested in taking a different involvement with PrEP.
Folks, my name is Mark. I'm with Emory University Hope Clinic, and I do outreach education for HIV negative and HIV positive studies. And it's very important that we get guys involved, anybody involved, to join into these studies. Now, if you're not interested, you may know somebody who's interested, so please take the information. We have tons of it out there. We are looking for negative men right now for an MSM proposal study, rectal proposal studies that are non-use relationships. So if you or you know somebody, please take some information up there. And we're also looking for a few folks that are HIV positive, that are lead controllers. And those are folks that do not need medication to control their HIV. And we have one for long-term Hep C co-infection study. So if any of you guys are interested, please see me. If you haven't signed in yet, please sign in. We also have a survey up there. It takes 2 seconds. Fill in the bottom if you're interested in participating in any study, and I will contact you to see if you qualify. Appreciate it.
And on a more personal note, Team Friendly is always looking for more people to be involved. Please take the time to like us on Facebook or check us out at www.teamfriendlyatlanta.org if I remember it. What? That's right, yeah. That's why Dylan's the smart one. Teamfriendlyatl.org. And do know that after we conclude in a moment, you will have a chance, if you want to ask questions one-on-one with the panelists. We encourage you to do that. We are hoping to have another similar town hall forum in the near future, so please keep up to date with us, and we would love to see you all at our next event. Thank you so much for coming out. We appreciate your support.
I want to remind people that there is a patient assistance program that will cover the medication for those that are uninsured. You have some criteria, you have to call the number. The patient assistance also covers HIV tests, hepatitis B testing, condoms, and resistant tests for those that would become or could become infected. The other program that is available is the co-pay assistance program, where you can get up to $200 a month to assist with your copay. There was a statement on the guidelines that says that GIA will contribute or could assist you with your medical bills. That's an error. GIA could not. It's not technically correct for us to actually help you with your medical bills. So again, medication, HIV testing, hepatitis B. It's on page 47. Yeah, assist with copay. I can show it to you.
Right, you said you do.
Medical visit copay.
It says medical visit.
Thank you again, everybody.
Not in the comments, but you can put it
Should I
in.
put my phone here?